from the American Academy of Pediatrics.
When a child dies, no matter how or why, it's devastating.
New guidance offers ways pediatricians can help families move through the unimaginable trauma.
What parents need is to feel that you are with them, that you are listening, and that you are there for them. So that really is the most important thing.
Plus, new research shows disparities in the dispensing of antidepressants for adolescents and young adults.
I think there is not a lot of clarity as to the exact reasons why antidepressant dispensing and mental health is going up and mental health is getting worse in youth.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about how pediatricians can support families after the death of a child.
Working in the neonatal intensive care unit is a joy and a privilege. But we do have infants who die, and it's hard on everyone.
You know, I know that's part of your job, Joanna, and honestly, it's one of the reasons why I couldn't do critical care. I also didn't pursue cardiology or hematology oncology because my experiences of grief during training felt so overwhelming. I'd like to think I've developed better ways of processing since then.
Despite this being a serious and often sad topic, I am really happy the AAP recently published new guidance in a clinical report on supporting the family after the death of a child or adolescent, because no one should have to go through this devastating situation without quality care, community, and compassion.
Thankfully, we have Dr. Arwa Nasir, professor of general pediatrics at the University of Nebraska College of Medicine and co-author of that clinical report, here to help us out. Dr. Nasir, welcome.
Thank you. Thanks for having me.
So to start, is there a way to predict how families might experience grief after the loss of a child?
Families go through a lot of different emotions after a child dies. And literature tells us that there are stages of grief, and those are shock, anger, denial, bargaining, and acceptance. However, we have experienced recently, not every family experienced those stages in order or in sequence. People go back and forth between one emotion and the other, and sometimes they go back to the previous emotion, sometimes they skip some of those stages. And the way grief is expressed or felt by different individuals and families is dependent on individual factors, individual temperaments, cultural factors, and the types of support that this individual may have around them.
And for families that know they have a child with a diagnosis that will result in their death, how do we help them with the experience of grief before the death of that child?
There is nothing that we can do that will remove the pain and eliminate the grief. Families are going to grieve. I think what pediatricians and other healthcare workers and also other members of the family can do is be there for that family through that grief and creating the space where families can talk about the grief if they choose to do that and be there for them. The different circumstances surrounding the death of a child, including whether this had been expected or unexpected, gives the situation a little bit of a different context. For families who have a child with a chronic illness or where death is expected, an expected outcome, sometimes people think that that might make it easier for them and that they're maybe prepared for it. However, those parents are going through, grief even before the child has passed away. And then even after the child passed away, a lot of times the experience is not easier for them. We hear that a lot from the families that although we expected this, we didn't know really it's going to be that difficult. So I think that the same principles of supporting the family in the other stages work here, which is basically just creating the space for the family to be able to talk about this and discuss it and be that listening, compassionate person who is there to let the family know that they are heard and that their feelings are appreciated and that we know that they're going through a hard time. And then offering whatever support they ask us for. But creating that space and the expectation that it is okay to talk about it is probably the most important part.
I work in a hospital setting and not a clinic setting, and children who are very ill are often referred to the hospital where I work. So death is something that we know and have to deal with, and especially in the acute care setting. What resources exist in hospitals to help with death and grieving?
I think if you have a palliative care specialist there, that probably would be your best ally. They are experienced with the situation and they can provide most support. This is my experience I'm a hybrid, so I work in the hospital and in the outpatient setting. And in the hospital, the palliative care professionals or specialists are really a tremendous support. Additionally, social workers who have a double duty. So they themselves, some of them have ability to provide counseling, but also they are a tremendous resource for connecting and knowing what community resources there are for the families outside the hospital.
You mentioned palliative care. Should a palliative care consult be put in for every child who's dying? When would you recommend calling that service?
You'll know it when you experience it. I mean, some families seem to really struggle. If you have that capacity, you can. I think at some point when you do it several times, you might be able to manage some things and not need the consult every time. But I would say that if you have that service available and it's not going to harm, I always learn from them. And you can do it if you have that ability.
At my institution, we use Child Life to do things like molds of the child's hands or other memory making. Should that be standard practice?
Well, some hospitals have different programs. In my hospital, we have something called the Helping Hand. It's a program that they've developed to help families cope with grief after death of a child in the hospital. And Child Life also can be used. Depends really on what is expected of them and what resources they have built.
Following up on that, the hospitals where I work have variable access to these services. What community resources exist for families who need help processing their grief?
There are a lot of community resources that we can refer patients to. One of them would be definitely grief counseling. There are community providers or maybe in the hospital who are specifically trained for grief counseling. Most general mental health providers and psychiatrists can or are familiar with grief and can support a child or a family who is going through that. But there are some individuals who are specifically trained for grief counseling. And if one has that resource, those are usually very, very helpful. There are some parent group networks that families can be referred to. I find that whatever you refer the family to, a little bit of letting the family know what to expect and a little bit of preparation for them, explanation of what that service is can go a long way in having the family be accepting of this referral. So just telling them, I know these people, they do a good job. I've worked with them before. They're helpful. For parent groups, sometimes I tell parents, I know some people just don't like to go and speak to strangers about their private emotions, but usually parent groups are very helpful. People who participate in them usually find them very, very helpful. So a little bit of preparation about those community referrals can go a long way in helping families be accepting and take advantage of them.
And I know that for me, probably the very hardest conversations that I have in practice are the first time that I sit down with a family when a child has died. And I think a lot of us feel that way. Are there better or worse ways that we can approach these conversations?
Right. I think one just has to realize that there really is nothing that you can say that is going to take that pain away or make them feel better. That what parents need is to feel that you are with them, that you are listening, and that you are there for them. So that really is the most important thing. Just expressing your compassion. I'm sorry this happened. It is really important. There are some things that we know that sometimes people tend to say that usually are not well appreciated. So trying to tell the family that, oh, I know how you feel. Well, that usually you can never know how somebody feels when their child dies. Or, for example, saying something like, well, he's in a better place now, or trying to kind of make them feel good that the patient is out of their maybe suffering. That also doesn't usually ring well with families. And again, you really are not intending to remove the suffering. You are just going to be there for them. And that this compassion, them feeling that you are there with them, that you feel their pain and have this empathy and compassion with them. This really is the highest value. It's not really anything that you can say that is going to remove their pain or make their pain less.
As a neonatologist, I think a lot about how infancy is a period of a child's life when there are really high mortality rates. Families, though, may also lose a child before they're even born. How do you provide specific supports to those who have gone through miscarriages or fetal loss?
This is such an important point. I think the biggest point here is actually to recognize it, because clinicians and individuals in general, just because we have not seen the baby or the child or the fetus, we don't seem to understand that this to the parent is a child. So it tends to be overlooked. And I think the same principles that we use with any child at any age can be applied to this period. But the most important thing is to really acknowledge that and create that space for the parents to express their grief and validate that, because sometimes they're embarrassed to say it, or nobody asks them and nobody really feels really what's going on. So I think recognizing that is very important. And literature says that it really a lot of times tends to go unrecognized, and those parents do not get as much support as parents of child who died after they were born.
I think being part of a family lends so much to our sense of identity. Are there ways that family members can preserve their identities as caregivers, parents, siblings, and other relatives after the death of a child? How do they do that when the child is not physically present?
Right. So commemorating the life of a child is an important step for preserving that identity, as you mentioned, and also for the healing process. So sometimes people tend to avoid mentioning the person, the child who's died, or to bring the pain again, but actually talking about that person or creating some kind of a commemoration, whether it's by creating a photo album or commemorating their birthday after they have died, can actually be a healing process. Those occasions that sometimes a birthday, a Christmas, an occasion, a trip to a certain place that person liked, sometimes can cause the pain to resurface. And trying to commemorate that instead of suppressing it actually can be, again, a healing process for the child and the family. So encouraging the family to be okay with that and to be talking about it is actually okay.
And I think David's question touched a little bit on cultural sensitivity, and you mentioned it earlier too, Arwa. So if you're caring for a family whose traditions you just don't know well, how do you educate yourself and support them?
So this is tricky. You can try to educate yourself about a specific culture. Culture is deep, and one cannot really master any culture by just studying it or educating yourself about it. I think the best strategy in this situation is to ask the family. Like we have been talking previously, families welcome this, and just asking them, how does your family like to honor the child? What are the traditions that you have within your family to address this situation. So I think asking families and getting their input, sometimes we hesitate to do that, but I think we know that that actually is what families want. They want to be asked about what would they like us to do? What would they like us to understand? It gives them an opportunity also to talk about the child and to talk about their culture and how they honor this patient. And that can also be quite healing and releasing for the family. There are some things also, some cultural considerations. For example, saying I'm sorry. One time I was in a situation where the family was Arabic speaking and the intensive care physician asked me to tell the parent that I'm sorry. Well, in Arabic, if you translate I'm sorry, this is kind of like you're apologizing. It does not have the same connotation that you are sorry like it does in English. So I had to think about how to convey that without the literal translation of the word sorry. So this is kind of a minor linguistic example, but there are a lot of cultural traditions within families that are either associated with the larger concept of culture as we see it, like being from a different country or from a different religion, or we have subcultures. We have family subcultures that every family has their own subculture. So asking families about how does your family like or want or prefer to do this would be really helpful.
You know, I've learned so much talking to you, Dr. Nasir, and I feel I'll have a lot to process from this clinical report. Do you have any last takeaways for pediatricians who want to be there for families when they lose a child?
Yeah, one thing we didn't talk about really that I think is very important are the siblings. A lot of times, families or parents can be consumed in their grief that the other children suffer because, number one, children themselves are grieving, and then they're seeing their parents grieving, and then the parent also is grieving and still have to take care of the other children. So the children are sometimes called the silent grievers, because usually people are paying attention to the parents, but not to the children. And I think that this is a very important role for the pediatrician to call that out and make sure that the parents, to support the parents in supporting the surviving siblings, and also recognizing that the better the parent manages their grief or adjusts to it, the better the siblings will. So I think this is an important part that sometimes we forget, but then the pediatricians have a big role in making sure that it is addressed.
Dr. Arwa Nasir, thank you so much for joining us today.
Thank you for having me. I appreciate it.
To read the clinical report supporting the family after the death of a child or adolescent, visit our website at aap.org/podcast.
Coming up, we'll look at trends in the dispensing of antidepressants. Joanna, I've shared some very personal stories on this podcast about the mental health challenges that my kids have faced growing up and helping them navigate those.
And I'm so taken when you do that, David, because talking about mental health care is hard and there's no universal treatment for it.
Yeah, therapy has to be tailored to the person listening to their stories, providing counseling, and at times also providing medications. You know that not only have we worked with our own children's struggles, but my wife, Christy, is a pediatric mental health provider working every day in this field.
I hear more and more even about our peers going on medications to help support their mental health. And I wonder sometimes how many children are taking these medications, especially as we adapt to the world after the pandemic.
Unlike so many things with the impact of mental health, we can quantify this. Pediatrics recently put out a paper, Antidepressant Dispensing to U.S. Adolescents and Young Adults, 2016 to 2022. We have the first author here to discuss that with us today.
Dr. Kao-Ping Chua is an MD, PhD, primary care pediatrician, and health policy researcher. He is currently working in the Department of Pediatrics and the Susan B. Meister Child Health Evaluation and Research Center at the University of Michigan. Dr. Chua, welcome to the show.
Thanks for having me here.
So I imagine you conceived this study as you saw the mental health crisis looming before the pandemic struck. But what made your team think to look at antidepressant prescriptions? What did you think you would find?
That's a good question. I think in my own practice as a primary care pediatrician, I certainly saw a number of youth, or an increasing number of youth, coming in with mental health concerns. I certainly had heard a lot about the mental health crisis in youth through the media, and I wanted to leverage my access to national prescription dispensing data to understand whether the concerns about mental health in youth were reflected in antidepressant dispensing trends.
And you mentioned you had access to this national database. Where did you get the data for this study?
The data comes from a private company called IQVIA, which is a big healthcare company that sources information from approximately 92% of U.S. pharmacies.
Knowing mental health is such a big issue, I would imagine prescriptions for antidepressants increased. Is that what your paper found?
Yeah, so we used 2016 to 2022 data from IQVIA to look at trends in antidepressant dispensing to adolescents and young adults aged 12 to 25 years. And we did find that even before the pandemic began in March 2020, the rate of antidepressant dispensing was increasing. But we found that this rate accelerated even faster from March 2020 onwards, about 64% faster. And it turns out that this acceleration was not homogeneous within sex and age groups. When we broke this down, we found that the antidepressant dispensing rate increased 130% faster among female adolescents aged 12 to 17 years than beforehand, 57% faster among female young adults. In contrast, the antidepressant dispensing rate didn't change very much at all among male young adults and actually declined among male adolescents.
I'm sorry, I'm just taking this all in, and I'm just so curious why the prescriptions for males or boys went down. I would have thought, like David, that all prescriptions were up. Why do you think that is?
Yes, that's a really good question. That was the most surprising finding for us as well. I suppose it's possible that the decline in antidepressant dispensing to male adolescents reflects improved mental health. I just don't buy that explanation in light of other evidence suggesting that the mental health of male adolescents worsened during the pandemic. A more likely explanation is that male adolescents simply didn't come in for mental health concerns during the pandemic. I think one of the reasons why this may have occurred is that the transition to virtual learning decreased opportunities for school staff to diagnose adolescents with mental health concerns. And those opportunities are particularly important for males because academic struggles and behavioral issues at school are often how mental health symptoms manifest in male adolescents.
So overall, there was an increase in antidepressant prescriptions for adolescents and young adults, and this trend was starting even before the pandemic. What else should we be studying to help us understand this increase?
I think there is not a lot of clarity as to the exact reasons why antidepressant dispensing and mental health is going up and mental health is getting worse in youth. I think during the pandemic in particular, there were way too many factors that you potentially could point to, and they all kind of happened at the same time. So it's kind of really hard to tease apart which one was the most important. So for example, for some youth, it may have been social isolation from stay-at-home orders. For others, it may have been that their parents lost their jobs or even potentially died from COVID-19. For still others, it could have been that some of their longstanding friendships got severed due to the polarization over COVID-19 restrictions. And let's just not forget, of course, above all, that back in 2020, particularly, there was a lot of uncertainty over whether and when the pandemic would end. And that was scary for everybody, not just young people.
Kao-Ping, this has been such an interesting look at the well-being of our children. Do you have any last takeaways before pediatricians go read your paper?
I think that pediatricians are the front line for many adolescents and young adults with mental health concerns. I think that if they're not already doing it, pediatricians need to just routinely incorporate screening for mental health concerns into their visits for adolescents and young adults. And I would add that it may be particularly important to dig a little deeper when it comes to male adolescents, just because it's possible that some of these concerns are hidden. If my theory is correct, and the decline in antidepressant dispensing to male adolescents reflects just not coming in for mental health concerns, then what we may be seeing is underuse of antidepressants relative to the level of need. And that's a very concerning possibility because it's really important for all people with mental health disorders to get the most effective treatments, thus improving their quality of life and maximizing their potential.
That is great advice. And Dr. Chua, thank you so much for joining us today.
Thank you.
To read the paper, Antidepressant Dispensing to U.S. Adults and Young Adults 2016 to 2022, go to aap.org/podcast. This week, instead of say, we're bringing you a giving voice, where we hear from other pediatricians in our audience.
Dr. Lindy McGee is a member of the AAP section on tobacco control and an e-cigarette chapter champion for Texas.
I don't know about you, but I'm old enough to remember smoking sections in restaurants and on planes. I remember going to my aunt and grandmother's houses and feeling overwhelmed by the smell of cigarette smoke. And then came the tobacco settlements and the anti-smoking policies and the campaigns that worked. Smoking was seen as a gross habit, and its health consequences were well known by everyone. As a young pediatrician, I did not see many teens who smoked. And as a young mother, I was thrilled my kids had no idea what smoking was. It was a public health triumph. And then came Juul and all those other vapes, and a new vape shop at every strip mall I pass. I had patients telling me that they were just vaping flavors, not understanding that there was nicotine in them. I saw a 17-year-old patient who came to me after a hospitalization from lung injury due to vaping. I saw a 16-year-old patient who was waking up with headaches every morning because he was going into nicotine withdrawal every night. And I had a 15-year-old patient who asked me what I thought about those new Zen nicotine pouches. It's easy for trends like this to make me feel despondent. The tobacco and vaping industries have deep pockets and highly addictive products, and we're just pediatricians waking up and fighting the good fight every day. But we have won this public health fight before, and we know it works, and we can do it again. The AAP has an excellent model for us to follow, ACT or ACT, to promote youth tobacco cessation. Ask about tobacco use, and specifically ask about vaping and other nicotine products during every possible clinical encounter. Counsel all youth who are using any cigarette, nicotine, or vape product to quit. Have them set a quit date within 2 weeks. Treat patients who are using these products by linking them to behavioral support, such as telephone quit lines or text-to-stop programs. Consider adding pharmacologic support, such as nicotine replacement therapy when indicated. It's also important to encourage patients who aren't vaping or smoking to continue down that path. It's worth a little bit of extra time. Because I came of age professionally when teen tobacco use was low, I'd not learned how to do all of this. Fortunately, the AAP has some really good resources to help. One I really like to use is AAP's Tobacco Cessation web-based decision support tool. When I'm with a patient who's using these products, I can easily pull it up and go through the treatment algorithm to make sure I'm offering the best counseling and treatment plans. Believe me, I am so frustrated that we're in a position where we're having to really focus on this again. But we all remember in medical school seeing the older patients with lung cancer who were so addicted to smoking that they were smoking through their trach. And we went into pediatrics because we love the idea of disease prevention. So let's gear back up for this fight. Let's act to prevent and treat tobacco product use. It's a battle I know we can win because we've won it before.
Thank you so much, Dr. Lindy McGee, for giving us your voice. To view and use the Youth Tobacco Cessation Progressive Web application, visit aap.org/helpkidsquit.
That's it for today's episode. If you'd like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss the role of the pediatrician in the promotion of healthy, active living.
We'll talk to the author of a new clinical report, Dr. Chris Bowling. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.